Hi guys, thanks so much for watching Speaking of Founders Mission. I'm Stephanie, and today I'm with Dr. Apurv Gupta, who is the Director of Performance Excellence at Guidehouse. Thank you so much for being here.
Thank you, Stephanie. Thank you for having me.
Of course, I can't wait to talk to you and learn more about your mission, which is to improve patient care through the healthcare system. So tell us, why is that your mission, and how do you work on that?
So interesting. Well, I guess many different ways we could approach that. I guess to start off, why it became my mission. Way back when I was in medical school, I kind of got interested in public health and community health, influenced through some friends actually, who were with me in medical school, and so I decided to do a master's of public health, which I finished at the same time that I finished my medical degree, and that really lit the fire inside me. I kind of really felt like, understanding public health and management and systems thinking, that I could, somehow make a bigger difference to healthcare than I could, at an individual level. So that's really where the fire got lit. And I got really excited about pursuing a career in performance improvement and healthcare management. So pretty much all along the way, now that was a long time ago, but pretty much every single step of the way, I kept looking for more and more opportunities to just get better at understanding performance improvement. And so here I am, probably it's been 30 years later.
That is a really cool story. I love that you got your master's of public health at the same time as your MD. That could
Yeah.
not have been easy. How in the world did you pursue two goals that are very demanding at the same time?
Yes. Well, it's a little known secret, but don't tell anybody but yourself and our audience here. But I actually took a year off between third and fourth year of medical school. So
Yeah.
I extended the process and what's already a pretty long process, I decided to make it even longer.
Um,
But I figured that was the best way for me to get value out of that training rather than just try to jam it in. I felt that it made more sense to actually focus on that for a year.
wow. That's definitely not a path that you hear many people take. And so whenever you finished medical school, then did you work as a doctor?
I did, yeah. So I always worked as a doctor, but because I'd already finished the MPH, and that really bit me. Every opportunity I sought after that, including internship and all my jobs, I always wanted to make sure that there was a performance improvement, healthcare management angle to it. So for most of my career, I think I practiced about 50% as a clinician and about 50% as an administrator. And then over the last 10 years, I've moved more into full-time administration.
Do you feel like your background working as a doctor helped you in your goal in public health?
Oh yeah, absolutely. I think that public health, you're trying to improve care for a population of patients, and it really helps to understand, how the healthcare system works, how care works at an individual level, because you're really trying to sum it up in some regards, in a more global way. So I think for the work that I do particularly, there are a lot of people that do public health. That do it, for state government or federal government. I think that work sometimes is a little bit different. But for a lot of the work that I do, which is with working with hospital systems, it really helps to understand how healthcare works for individual patients.
That has to be such an asset. And what have you noticed whenever you were working as a clinician? What were the things that really stood out to you as problems that needed solved, especially thinking with your public health brain?
Yes. Yeah, and that becomes apparent right away, even if you don't have a public health brain. Unfortunately, the challenge in healthcare is that the system is so dysfunctional in many ways that we all experience it as consumers, as patients, as family members. And so you can imagine, as a physician, as a nurse, or any other, healthcare worker, unfortunately, on a daily basis, you see all of the things that aren't really working. You see the communication, gaps that happen, doctors and nurses, failing to connect, doctors failing to connect with patients just because everybody's busy running around. So you see a lot of those issues happening. Protocols that aren't really followed, care that could have been a little bit different if we had coordinated it better upfront, but that doesn't really happen. So once you start practicing medicine, you kind of see that right up close and personal. And unfortunately, it leaves a lot more to be desired. That's sort of where you start to understand there's so much room, for making the system better. We're all trying as best as we can. We have some very, very dedicated healthcare professionals and administrators. Everybody's trying the best they can. The challenge is that everybody's trying to optimize within their individual spheres, and we don't often come together to figure out how can we be collaborating, better. How can we be more proactive in figuring out what the system should be?
You told me before that you think that patients need to have an advocate because they can really just get lost in the system. Almost it seems to me kind of like a ping pong ball when you describe how they're between all of the people. And
Yes,
so, whenever you're focusing on ways to improve the system, do you start with the patient or do you start somewhere else? Where's your starting point that you
yes.
branch from?
It's such a great question because it's almost like a mantra now in healthcare to say patient-centered healthcare, which is true, and you hope it's true. You certainly hope that everybody really believes it rather than just being a saying. Unfortunately, once you start working on healthcare, there are a lot of other stakeholders. There's physicians, there's nurses, there's administrators, revenue cycle, finance people. Everybody has their own little angle to things. But remembering that the patient is in the center is often the best way to ground everybody. When people start pulling at the strings and start trying to pull, in one direction or the other, it's very, very helpful to keep reminding everybody why we're doing it. You remember, we're not here for ourselves. We're not trying to maximize revenues. We're not just trying to make our workday easier. We're not just trying to make the system, self-sufficient. We're doing all of those things. That's true. But we're doing those things with an eye to how do we make the care better for the patient. So it's a very important, I think, principle, or you could say value, that I think really can help guide us in healthcare and help us find kind of our true north.
It might sound kind of crazy because the whole reason that people get into the medical field is to take care of patients and, maybe solve diseases, figure out cures for diseases. But how do you get buy-in from these people? Because I'm sure it has to get into a thing of like, you're a doctor and that at some point it becomes a job, or a grind. And same
Yes.
with nurses, they're running from one patient to another. And then you have things like this with COVID-19 that pop up that complicate everything. How do you
Yeah.
get buy-in to get them to focus on the whole picture of really advocating for the patient and keeping that patient at the center of the care?
Yeah, well, I think in your statement and question itself, I think, Stephanie, you bring out the answer, which is just really reminding people why they went into healthcare in the first place. You can't really be in the work of improvement. You can't really be trying to help make things better unless you have some sense of optimism and some sense of possibility. So I think you always have to start that conversation with reminding everybody of the values, their personal values, the values as an organization. What is the mission, vision of the organization that we're here to serve? And how can we remind ourselves of that as we set about? Because we don't ground ourselves in our values, then unfortunately you wind up bringing a lot of baggage to the table. Physicians have very much then become interested in preserving their workflow, in preserving the quality and the interaction with their patients. They don't really want things to interfere with what they're doing. And of course, they've got to worry about revenues as well, because they're usually independent businessmen and women, that are trying to make a living. So if you don't, reorient people to values, it becomes really hard to then get the conversation going in the right direction.
So once you get everybody on the same page, what types of solutions have you seen work or make improvement? What gives you hope that we can fix the system?
Where I find that we have made the greatest impact is really in that personal connection. You can't really think about the work of improvement as just widgets or as engineering or as systems that can be fixed. All of those things in healthcare are run by people and in the service of other people, the patients, right? So it's really still very much a people-centered business that has somehow become overrun with process and with systems and with technology, all of which is designed to help the people side of the connection, but sometimes that gets lost. Where we think we can make the greatest difference is when you remind the people what it's about. Again, going back to connecting them to their values and then to each other's values, to shared values, and getting them excited about the work. The best work comes from the people themselves. So I'm a consultant. I've been doing consulting in healthcare for about 7 years. Prior to that, I was working in hospital settings doing performance improvement. But the main thing that we bring as consultants, even though we may have a lot of experience and a lot of expertise and a lot of ideas, I think the one thing I've really learned is that the best solutions come from the client themselves. They know what works. Many people at the client really have and know what works. They've tried it in some setting and it's worked. They just haven't been able to really fully elaborate it. Maybe it's just worked on one particular unit, or maybe just on the night shift. One particular nurse somewhere has somehow figured out how to make the system work. And I think that the more we can come into a setting with an open mind, with reorienting everybody to the purpose why we're there and get them connected to that purpose, and then really start listening to them as to what their solutions are, the more likely we are to succeed.
What are some of those things that you see that really do make those units or those hospitals function well?
So I think that again, the simple thing here, which is maybe surprising to a lot of people, or especially who are not in healthcare, is that the greatest issue is communication.
Mm.
The greatest challenge in why healthcare breaks down and why patients may not feel like they're at the center of everyone's attention is because the communication isn't happening the right way. We're not talking with the patient. We're talking maybe around the patient. We're not talking with the patient in the room. We're trying to communicate through the chart with each other. We're not talking to each other. So probably the most important thing that we can do to fix things, and that's what we try to do, is find forums to improve communication. So I work a lot with health systems in inpatient settings, and one of the simplest and most evidence-based strategies that we help health systems implement is a daily touch base between a nurse, physician, and a case manager that are all caring for a patient. We try to help health systems figure out how can we ensure that there's a daily touch base on every unit for every patient. Those three principal caretakers are touching base to say, here's what's going on with the patient. Now, in more advanced health systems, that's actually happening inside the patient room. So the patient's also involved, and other clinicians are also involved, like a physical therapist or a pharmacist will also be involved. But at the very least, if organizations haven't gotten to that point, they should at least start with physician, nurse, and case manager, who are all three trying to independently optimize the care for a patient, to at least make sure they're talking together once a day. 1 minute per patient really doesn't take a lot. Actually, it's surprising. In 30 minutes, you can discuss every single patient in a given unit. And at the end of that session, everybody feels like, oh, I learned a little bit about what needs to happen for this patient. And I know what I need to communicate to that patient. I also need to know how I can continue to keep the patient's journey moving along. Other health systems, then introduce an afternoon huddle. So they touch base in the morning and they come back, same people in the afternoon, and say, okay, so how did we do? Did we cover the items we discussed in the morning? We may have identified a barrier. Maybe we couldn't reach a family member, or we couldn't get a test done. So let's come back in the afternoon and discuss how did we do. So it's simple communication. Unfortunately, it isn't happening because one person is relying on the other to do it, and we're making a lot of assumptions. And in the midst of all those assumptions, things don't happen.
That's interesting because I've had too many interactions with the medical system since 2015. And in the situation of my daughter, who was born 3 months early, she was in the NICU for 3 months. Every day, between 9 and 11 or whatever it was, they did rounds with everybody and all the babies in the unit.
Yes.
And the parents were welcome. And it was so great because it was the neonatologist or the nurse practitioner with the nurse, with the dietitian, with the respiratory therapist, and any other specialist that might be required, and then the parents. And it was so great being able to hear that because everybody was hearing the same thing. There wasn't a chance to miss anything. Then in a different experience that was an outpatient setting with somebody else, not my daughter, you don't have that situation of the cohesive unit. And so it is sometimes just like a game of telephone where you're trying, well, he said this, well, she said that, and then, well, he told her that. And
Yes.
so the patient's stuck there in the middle trying to figure out what it is. So to your point, being able to have those meetings and just have everybody on the same page, it eliminates so much strife and time and
Yes.
duplication of work or unnecessary work.
So true. See, now you've become a performance improvement expert. That's exactly it.
Who
Yeah,
knew?
it's so true. It's just understanding, seeing, observing. I mean, you saw it there for yourself. You see it there for your family members. There's not a single person who's going to be listening to this that won't be able to recognize this for themselves. Unfortunately, this is the reality of healthcare today. No matter which health system or clinic you go into, you're likely to encounter some communication gap because we're not approaching it again, it's a pretty simple intervention. Now, that by itself is not going to solve all of healthcare's woes, but interventions like that are all based around these principles of grounding ourselves in the values, keeping the patient in the center, and improving the communication, connecting from clinician to clinician instead of just trying to play that game of telephone tag that you were saying, or trying to communicate through the record, which is unfortunately even worse game, because it's not even people trying to reach each other one to one. It's actually leave a note and hope that somebody will come and then read that note, right? So it's an even a worse game, because now you're expecting people to really chase after information, and this is not the way care can be delivered, should be delivered, and certainly we have plenty of evidence that this is not the right way to organize care. It's I guess again, looking at the glass half full side of it, you're a little bit discouraged when you think it's 2020 and we're still operating in a healthcare system that hasn't fully embraced team-based care. But the glass half full side is that more and more you're hearing team-based strategies emerging in many settings, in hospital settings and in primary care settings and behavioral health settings. Everybody is kind of realizing that if you want to make care better, get the people that are all in charge of trying to make it better for the patient, get them to sit in the same room at some point, maybe daily, maybe weekly, and have them at least discuss what's going on so they can all be on the same page.
Mm-hmm. I think that also helps with the patient experience in a different way, because when they're in the same room, I think then you can send the same message. And to go to a different personal experience, when my dad had cancer and ultimately ended up dying of that 10 days after my daughter got out of the NICU.
Oh, sorry to hear.
We were talking to one doctor and they were going to do a surgery and to put a trach in. And so you become hopeful for that. But then we talked to the heart surgeon, came in and said, his cardiologist came in and said, there's no way we're doing that. His heart's functioning at 10% capacity. He can't handle this surgery.
Yeah.
So then you have to move to comfort care. But if you would have them together, or even if they would have communicated first, then they could have sent the one message and delivered it one time. And you're getting that blow one time rather than having the up and the down.
Yes.
There's so much value to everybody being on that same page.
So true. So true. I mean, again, another great story. I'm sorry you had to go through that, Stephanie, but I can feel that pain, kind of, you're not only dealing with someone who's really sick and may not make it, but now you're dealing with conflicting information, so the one hand, sometimes there's lack of information, sparsity of information. And now what you're talking about is conflicting information, because one person thinks we should do something differently and they're going to communicate that to you, but they didn't take the time to really make sure the entire team is in sync. And I think that's a really, really valuable improvement effort that we can make, is making sure that there's team coordination, that the key parties, the specialists, everybody is in sync before we are, figuring out what to communicate and how to communicate to a family member. If we don't do that, it winds up leading to not only the heartache on your side and the patient side, the family member, but it leads to a lot of unnecessary care being provided, because if that hadn't happened, now, say the cardiothoracic surgeon comes in to you and says, oh, well, gee, I guess I didn't realize the other physician said they should do the trach. Let's proceed, right? Because now maybe they're feeling hesitant or nervous to countermand each other. They don't want to undermine confidence in the system, so they back off. And now your dad winds up getting a treatment that really wasn't necessary and may have been more painful. It may have only prolonged his misery, not really made it any better. And all of this stuff, unfortunately, especially at the end of life for many people, is happening in a very, very broad way, because again, a failure of communication, because we're not able to have the conversation with each other, but we're also not having the conversation, as honorably and respectfully with you and with your dad, say, what would you have wanted? What would you want? If we could have had that conversation, even when he was in the hospital, but ideally even, months before he was
Mhm.
in the hospital, to have a respectful conversation to understand what are your values, what is your expectation, what would you want to have done, so then we could be aligned with you, and then we can be aligned with each other. All of these are opportunities to help improve really the outcome for you and for the family. And at the same time, when we do that, we're not only more respectful and caring, we get a better outcome. But many studies also show that that's a good way to get rid of all of this unnecessary care that we're providing, that may be up to 1/3 of what we're spending in healthcare. So healthcare is more than a $2 trillion enterprise right now, and the best estimates that we have are approximately a third of that may be wasted, in services that are not necessary, because again, we're not either following the best evidence, or we're not coordinating the care properly, or we're not communicating properly. So that leads to a lot of this variability, and that's kind of where opportunity for performance improvement really arises.
You brought up another good point about that and the unnecessary care. And when you and I talked previously, you mentioned that the busyness of the doctors and the nurses and other staff members can contribute to the lack of communication and things like that. And if they would communicate first, then you may be able to save all the time. In the example using my dad, there might have been a team getting ready thinking he's going to get surgery to have this tracheotomy. But so they're all doing unnecessary work that then the other doctor comes in and says, no, there's no way that's happening.
So
So you're
true.
spending the time on the man hours for people prepping that, which also takes them away from time that they could be spending with patients
Yes.
and allow them to focus on other things. So if they could communicate, you could improve everything from the cost of the healthcare to the quality
Yes.
of the time that they're spending with the patients.
So true. I mean, again, amazing. I think you're identifying all the key levers, and again, tongue in cheek, but I think you're really a performance improvement expert yourself. The way you're identifying these things, but the irony is that when you make care better, it gets better for everybody. It
Mhm.
gets better, just like you said, that care team that was off on the side potentially planning for something that didn't need to happen might have wound up using, collectively, maybe, or several hours of man hours, trying to pursue something that really wasn't necessary. So they would certainly have loved to have that time back so that they could focus that time on patients that actually needed, that the care that they could deliver. Everybody's busy.
Mhm.
The doctors, rounding in a hospital setting may have 15, 18, 20 patients each. The nurses may have, 4, 5, 6, sometimes even more patients each. It's really, really busy. Case managers sometimes carry 20 to 30 patients. Everybody's busy. So they certainly don't want to be, using their scarce time chasing after things that really are not required. So everybody actually appreciates the outcome when you sit together and coordinate the care and make sure that everybody's aligned, and you improve coordination of care, you improve the patient experience, and you improve the provider experience. The challenge is that independently, people are not able to come to that realization to say, hey, why don't we take 30 minutes out of our day and just sit down? Yes, it may seem like a lot because we're all so busy and we're like, oh my God, where am I going to get 30 minutes from? But if we take that 30 minutes, we're going to wind up saving more than 30 minutes somewhere else, because we won't be chasing after each other, or we won't be doing things that didn't need to be done. So you're absolutely right. Those are the principles of performance improvement. Is generally, when you improve care, it improves not only for the patient and the family, but it improves for the provider, and costs also go down. Which is kind of, sometimes you may say, paradoxical. Is that, can that really be true? But in general, that's what we found. Which what makes this field so exciting, particularly, is that when you improve care, you can actually improve a lot of different variables and outcomes. You can improve quality, you can improve experience for providers and patients, and you can reduce costs at the same time if you work on it the right way.
You've said that one of your areas of focus is driving sustainable change in healthcare to improve the bottom line by up to 25%, which sounds impossible.
Yes.
So once you identify all of these things that need help, and communication seems like one big thing, and also you've mentioned that the payment mechanism is broken. So when you identify those huge areas, how do you then go in and implement them to make that change on the bottom line?
Yeah, and so that's because it's such a complex system. It's really the medical industrial complex. There's things that you can do, and then there's things that you may not be able to do, right? So it depends on your scope. I'm fortunate that I work for a company. Guidehouse is one of the largest healthcare consulting companies. We recently, I used to be working for a company called Navigant, and that was acquired by Guidehouse. So now we're a really big company, and we are one of the top healthcare companies in the U.S. And in other countries as well. As a result of that, we've got a fair amount of scope, which means that we can go into a healthcare system and maybe have 50 people, 60 people as consultants working alongside with the executives on many different areas. So if we do a project in that fashion, then we actually have the potential to change multiple, parameters. We might be able to go in and change the payment mechanisms. We might be able to go in and change, the workflows, for physicians and nurses in the inpatient setting, as well as in the outpatient setting. So a little bit of it depends on the scope at which you're operating, and how you're trying to make the improvement happen. But even if we're not doing, operating in that fashion, with some other clients, sometimes we just have very small projects. We might be only working on a very small piece of the pie, such as implementing multidisciplinary rounding. That might be the only thing that we're doing. Or we might be coaching leadership on how to improve engagement, of their team members. So if we're doing individual pieces, then obviously, as you can imagine, our task there is to do that as best as we can, helping ground the work as much in the individual stakeholders' values as much as possible. Try to connect that work to other work that our client may be doing, so they don't just see this as piecemeal work, and try to push the ball, a little bit further. The big change that when you say, up to as much as 25% of the bottom line, the big change really happens when you connect a number of these initiatives together. That's what really leads to more fundamental culture change, leadership kind of operating at a different level. You can improve their governance system. You can improve help them develop change management systems. And that's when you can really see a bigger change that can make dramatic impact to the bottom line. We've helped a client recently make, just in the clinical arena where I focus, a $60 million impact to the bottom line. This was a 4-hospital system in Philadelphia. And another client, we've helped them make more than a $20 million impact, to the bottom line. So you can make very significant improvement happen when you start to figure out how to connect the dots, and again, using the team-based concept not only for our clients but for ourselves.
What is the reaction like whenever you get in there, you assess what's happening, figure out the initiatives that you're going to tackle, put them into place, and then people start seeing the results? What is it like when you're dealing with the hospital administrators, the doctors, the nurses, the patients? What feedback are you getting?
I think in general, I guess it depends on level of execution, and all of this stuff takes time. So if you're going to make a $60 million impact, that's not going to happen quickly, right? That's going to happen over 2 years, maybe 3 years. It's a journey. It's a transformation journey that the client is on, and it will happen over time. So over that period of time, another rule of performance improvement is you try to get the small wins, because nobody wants to wait 2 years or 3 years to see the results. They want to be able to know that they're doing the right things and that the work that they're doing is starting to head in the direction that it needs to. So you try to figure out what are the small wins before impact actually hits the bottom line. Maybe the first impact that you'll start to see is that people are communicating better, or that the teamwork improves, or that patient satisfaction may be improving because we're having more touch points. So what we try to do is help clients understand what their journey is going to really look like, what some important milestones are on the journey, to have clear expectations, so we don't get too far ahead of ourselves and start thinking it's a failure. Say that again.
Communication.
Yeah, exactly. That's right. Yeah, be patient. Ultimately, uh, our expertise because we've done this in so many places, we know how, the time course that this usually takes. I think that's what clients really value, is that level of experience that we bring. We know how to guide and facilitate the journey, because we've been there and done that, and that can be really valuable to them. So they don't get all jumbled up in their approach.
What excites you about performance management? Where did your drive and interest in this come from?
Yeah, I think what excites me is ultimately at the core of it is just things get better. Improvement is really about improvement. And you take out all the semantics and you take out all the different terminologies, at different times, people probably will remember at some points we used to call it lean, other times we call it Six Sigma, other times we used to call it total quality management, total performance improvement. There's so many different labels that this can go under. And that bit becomes confusing, I think, because all of those systems are ultimately just trying to make change happen, trying to make improvement happen. That's what really grounds me is I feel that if once you understand enough of the drivers for improvement, you can see improvement taking root. You can see it at a very micro levels. You can see it in yourself because you're learning about how to make things better, and you can certainly see it in your colleagues and your counterparts. When I'm working with, for example, a chief medical officer, or medical director, chief nursing officer, those would typically be my counterparts on a client, and you can kind of see the wheels turning and the light bulbs going off and the realization happening about, oh, this is how we do it. We all know this stuff. We've heard about it. We've gone to plenty of seminars and webinars and stuff, and we've heard about all of this. But when they start to see how you connect the dots, the light bulb goes off. That's when you understand that what improvement really is. It's about a level of understanding that we can drive ourselves to as practitioners and as managers that then enables us to actually make whatever process we're working on better. And lo and behold, when you have enough people that actually are participating in that journey and that really get it, the process starts to improve. So then you can see the tangible outcomes. There's the personal outcomes that probably the most rewarding, at the level of the individual and kind of seeing their deepening level of understanding about how to make the change themselves. But to bring it all home, it becomes doubly rewarding when you can actually see that an end outcome that you wanted to make better, such as a patient experience score or quality score, or improving throughput, or reducing cost. When those things start coming together, then it's really gratifying that we're not just talking about things. This isn't just a feel good, sound good kind of a story. Yes, it's about connecting with people and respecting values and respecting each other and communicating. That's all feel good stuff, but it actually works, and you can see that happening at the level of the people that are in charge of a system, and you can see it happening at the level of the outcome.
When you were young, did you think that this was something that you would be doing, or has this always been an interest to you, finding the
Yeah.
best way to do things?
It really wasn't. It was a complete curveball, you could say, because when I was young, probably like most people back in high school, I can remember vividly, I had really no idea. I was just interested in math and science, and I was good at it. So I said, well, what am I going to do? And I was an Indian kid back in the 80s. So, at that age, being an immigrant, my dad is the one who immigrated here. So I was second generation, but I was, I'd also immigrated here. We didn't really know that much more about, options and career options. And so it was either engineering or medicine. And so that's how I chose medicine. I said, well, it sounds interesting. Nobody in my family is really a doctor. So why don't I, try it out? That's the level of understanding I had. It was more based on the understanding that this was about science and that this was just something interesting to do. And doctors are held in high regard, and what a wonderful profession it would be. It's not really until I got into medical school and then I started exploring community health and then public health that actually started understanding that I actually had a knack for that. As opposed to the science. I think I was pretty good at the science, but I don't really feel I was ever creative in the scientific arena. But in the public health arena, somehow that really unlocked my energy and my creativity. And once I tasted that, I could really feel that. I was experiencing it and deploying it, and implementing public health related interventions at just a different level of competence than the other science, math related areas of competency. So that's what really drove me. So it was still relatively early in my career, but it wasn't in childhood.
What do you hope that your work with all of this improvement can lead to with the healthcare system?
Yeah, well, I guess I can't be too grandiose about it because who knows where the overall healthcare system is so much of a juggernaut, and again a big industrial complex. So we'll see. But if I can have impact at my individual level, what I would love to see is that people that I work with, teams that I help to create, wound up becoming sustaining, and it wound up helping to develop leadership capacity, management capacity, performance improvement capacity in more individuals. And then those individuals went on to also continue to try to make, their little dent in the healthcare sphere. So I guess, that's what I most look forward to, is the ability to drive change by being inspired and by inspiring others. I think it's a very big Herculean effort, and the more of us that can get involved, I think that's what gives us the best chance of actually making a difference.
Thank you so much for sharing your story and all of your thoughts. I loved having you in the show and getting to know you better.
Oh, my pleasure, Stephanie. It was such a great conversation with you. Thank you so much.
Thank you. And thank you guys for watching. Bye.